Hello. First, can I just thank Imogen? Fantastic conference, as always. And actually, I was reflecting on this. This is probably one of the best melanoma meetings overall happening, and a very kind of unique thing. So thank you for organising that. So I'm Poulam Patel. I'm a medical oncologist in Nottingham. I spend half my time doing clinical work and half my time doing research. So the clinical work is melanoma and kidney cancer, and I do both of those because they're cancers which used to be treated with immunotherapy and still are. And the other part of my time is running a laboratory looking at the interaction between immune cells and tumour cells. So it's a great pleasure actually to talk about the latest news which was shown at the two recent conferences. And they are ESMO, the European Association for Medical Oncology, which happened last year, and ASCO, which is the American Society of Clinical Oncology. So these are general cancer conferences at which the latest clinical findings are shown. So at ESMO, there's about 24,000 attendees. It was in Munich this year, and it covers a whole range of different cancers and gives you updates on all of those. And similarly with ASCO, which is a little bit larger. What's really encouraging is over the last 10 years, everything used to be, if you had good breakthroughs, they always used to be shown at ASCO. But now many of them are shown at ESMO first, and Europe is taking a much larger role in this. And one of the surveys showed that about 10% of the oncologists who were at ASCO this year said that melanoma was one of their main interests. When Pippa and I first started going, I started going a bit before you, and the melanoma room used to be about 15 of us sitting there because there was chemotherapy and it didn't quite work very well, and there were lots of things being tried, but very little was coming to fruition. Last year and the year before, when we went and Pippa was presenting your thing, the audience must have been daunting. It was a massive room with hundreds of people, thousands of people actually. So the field is moving lots. So I'm going to try and summarize just a few of the things. And what they have is presentations there, and then lots of posters. And about, so this is the size, sorry for those guys who are looking on that side. This is the size of the conference rooms, massive when they have the big plenary lectures. So I'm just going to pick out a few of the things which are there. So what I'll talk about is some background first of the things which have happened before and why we're here, and then focus on a few of the things which I know we're going to cover again later, Neo-Adjuvant Therapy, brain metastases, and then the follow-up which we've got from previous studies. So at many of these meetings, we'll hear the first look at the data, and that might be quite early on, but then actually you want to know what happens 2, 3, 4 years later to those patients who are in the trials, and we've got some of that. So just by way of background, so the last 5 or 10 years have been massive changes in the treatments with the BRAF inhibitors and with the immune checkpoints. So again, when we went to melanoma, when we went to ASCO and ESMO, you would be in small rooms listening to not very many breakthroughs. Now, every year there is more and more things happening, and the last 4 or 5 there have been particularly good ones. So when I spoke at a similar sort of thing last year, I was presenting some of the adjuvant treatments, and I'll just kind of go over a bit of that. And the treatment up to now has focused mainly on stage 4 disease, the metastatic melanoma, and then more recently in the adjuvant setting. So I'll talk a bit about those two as a way of background. So this is the survival graphs, and I'll talk a bit about that. So right at the bottom of that graph, I've superimposed the survival graph for what chemotherapy used to look like. So this is adapted from Georgina Long's talk, and each line shows the survival from a particular study, and they're not all this, over time. And the first one, so that's what the chemotherapy looked like. So we look at survival graphs all the time, so I kind of just comprehend it, but I'll just go through. So what it's showing you is the number of people who were alive at the beginning of the study, and then as time goes on, as less people survive, that graph starts dropping. So what this graph shows is that about 50% of the patients in that study had died at 9 months. And the 2-year survival was about 20%, but actually we know that longer, that 3, 4, 5-year survival is only 2%. So the first one was Ipilimumab, which showed some improvement there, but it was the long-term survivors which was very interesting. And now with the BRAF inhibitors, every year this line keeps going higher and higher and higher, meaning more and more people are surviving. So what does that actually look like? So this was, someone had asked me to put together something a bit more graphic. So with chemotherapy, if we started with 100 people, then by about a year, only 30% of patients would still be alive. By 2 years, that looked like about 20%, and then at 5 years, only about 4 or 5%. With Ipilimumab, which is an immunotherapy, which basically is one of the brakes on the immune system. When you release it, the immune system can recognize the cancer and then in some people be able to kill cancer cells and in some people eradicate it completely. So again, with that, what we found at 1 year, survival was about 50%, at 2 years, 25%, and then this bit, which was encouraging, that about a fifth of people were long-term survivors. And then with the PD-1 inhibitors, the second checkpoint inhibitor, if you like, which works in more people, a lot less toxic. Pembrolizumab I'm showing, but nivolumab does a similar thing, where you had the 1 year survival at 30 and 50%. That was now looking like 70%. At 2 years with PD-1 alone, that looks at like 50%. And then at 4 years and 5 years, we know that that's 40%. We now know that you can use a combination, which Pippa was showing earlier, and I'll show you the updated results of that. So that is great progress, but not enough, clearly. So what people have been doing is looking to see, can you use this earlier on to try and eradicate things? And we saw at the beginning that issue about dandelions and things, and I'm not sure I like that dandelion analogy, because every time I go in a field, I think I'd start thinking, instead of enjoying it, I think I might not enjoy it, but I don't know. So with this adjuvant treatment, you might have your primary taken off and it hasn't spread at all, and so actually you're fine and you've survived, and you just carry on. You don't know you're fine, but thankfully for many people you are. With some people, however, there will be microscopic spread to the lymph node, and that may either be taken out when you have a lymph node biopsy or when you have that lymph node taken out, and you're clear as well. But there's some people in whom you take it out, but there are microscopic deposits. We don't know they're there, those dandelion seeds. And you can have it cut out either a sentinel lymph node or there, so you're a stage 3, we would call it, fully resected, and you don't know if you've got microscopic metastases. So until recently, we've waited until they've grown and we know they're there, and that's when you've had the immunotherapy with a view to try and get rid of those. But the aim here is, can we put that treatment earlier when we've got resected stage 3 and then treat there, can we treat here and try and get rid of those microscopic metastases? And that's what the adjuvant therapy is, and can we get rid of those dandelions? Maybe I should use that analogy more, but I'll come back to that. So all the trials which we've had, and which were presented, probably 2 years ago now at ESMO and ASCO, patients who had microscopic metastases, who had stage 3, may or may not have had microscopic metastases, got treated for a year or with placebo, regular scans and follow-up, and then we measured with that time to relapse and survival. And I'm just going to show the results from a couple of those. So one was with pembrolizumab, and what we're looking at is not the overall survival, but when did the cancer first show itself again. And with the pembrolizumab in the placebo group, you can see that at a couple of years, about 50% the cancer came back, but in the pembrolizumab, that's gone up. And so there's a significant number of people whose cancer has not come back. And then with the dabrafenib and trametinib in patients who had BRAF inhibitors, again, a massive difference, at least that's what we would call a big difference, in survival, in their cancer coming back. So there's a group of patients here at 4 years whose cancer didn't come back. So that's the background for adjuvant therapy. And one of the startling things, or one of the things that really caught my eye at ASCO and ESMO this year was, was the neoadjuvant treatment. So could you, instead of waiting till you have your operation to take your lymph nodes out, actually do that earlier? So could you go from, instead of doing it there, could you do it before you had your surgery? And there's, from other cancers, breast cancer and some of the other cancers, using your chemotherapy up front before you have your surgery seems to improve the overall outcome. And that might be partly about the time, but with immunotherapies, it might be having the lump there with all of the cancer. Actually, the immune response, if you boost the immune system or take the brakes off the immune system, you've got a better anti-cancer immune response. So one of the trials which was presented was by Christian Blank, and this was a multi-center study looking at neoadjuvant Ipi-Nivo, and it was based on an earlier study which they presented, where what they did was they took patients who had stage 3 disease, didn't know if they had metastatic cancer, and gave them, either had their surgery and then they had they had Ipi-Nivo for 4 cycles, or they had 2 cycles of Ipi-Nivo, then had their operation, and then had a further 2 cycles. And what they looked at, because in the group who had their surgery after Ipi-Nivo, you could take out the tumour, look at it under the microscope, and look to see how much cancer was still there. And they call that, and then you could look at the response there, and you call that a pathological response, meaning you've taken it out, you've looked at, the pathologists have looked at it, and it's a response. And so what they found was that a large proportion of these patients who had 2 cycles of Ipi-Nivo before their surgery, 78%, had some kind of pathological response there. And actually 3 years later, all those people were still disease-free. And they did some absolutely stunning work on both the tumour and the blood. And what they found was in the group who had the neoadjuvant treatment, so immunotherapy before their surgery, that the response. So they took the blood cells, they took the white cells, and looked at all the lymphocytes and looked to see how broad an anti-cancer effect you have. Okay. And they found a much increased response. So however, 90% of the patients got really bad toxicity. So clearly they needed to do something to change that. And that's what they presented at ESMO. Christian presented was a modified Ipi-Nivo, and just 2 cycles of Ipi-Nivo as they normally give it. Doses changed around, so less Ipi, more Nivo, and that is known to be a slightly better tolerated, and then trying to give 2 Ipis and 2 Nivos. About 80 patients were randomized, and what they wanted to look at was could they get the same amount of response and but reduce the toxicities, and they did. So if you look at the top, that's the number of adverse events at grade 3 or 4. They brought that down to 40% and 20%, and also the response rates seemed to stay high. And when they followed those patients up, those people who have had a pathological response are doing really well. So the next part of this is to try and increase using the Ipi-Nivo earlier, and they're going to be looking at different regimens. That whole concept of using neoadjuvant treatment, so this is a really encouraging thing. What we're seeing in melanoma, probably more so than a lot of the other cancers, is groups across the whole of the world getting together in big consortia, putting heads together and pooling their resources and things. And so what they've done is they've looked at, and what we heard reported was a pooled data from 4 or 5 different smaller neoadjuvant studies. And what they found is that immunotherapy neoadjuvant both seem to be helpful, but neoadjuvant immunotherapy seems to be a good thing to do, and there are now trials opening, so with your stage 3 you'll do that. So very quickly, in summary, neoadjuvant treatment looks promising, broader immune responses, less toxic regimens are being looked at, and we may be able to predict who benefits. Brain metastases was the other area where the big breakthroughs, and there were 2 studies which were presented. One was radiotherapy, adjuvant radiotherapy after SRS, and the second was Ipi-Nivo in treatment. So the background really for the adjuvant therapy was SRS seems to work. Despite that, there's a certain number of lesions you can do, but a lot of people do then develop more metastases. So could you use whole brain radiotherapy like you can in other cancers to reduce the risk of treatment coming back? And there are some studies which suggested that you might be able to, but only a few melanoma patients were in there, and there are lots of other cancer patients. So the question was, does whole brain radiotherapy reduce the chance of the cancer coming back? Is survival better, and is quality of life better? And this was a large study run from Australia where patients who'd had stereotactic radiotherapy who hadn't relapsed, went on to have either observation or whole brain radiotherapy. And actually, although the recurrence rate was a little bit less, the overall quality of life wasn't, and the overall survival was not helped. So neoadjuvant radiotherapy, adjuvant whole brain radiotherapy after SRS isn't helpful in melanoma. And then Checkmate 204 was the next study, which was looking at Ipi-Nivo in melanoma, did 100 patients who'd had cranial metastases. And there are 2 cohorts which had asymptomatic brain metastases, which is increasing in number, but still the minority, and then a small cohort of symptomatic metastases, and they had Ipi-Nivo afterwards, and what they were looking at was what was the response rate and overall survival. And this was very encouraging. Basically, the response rates overall were in the region of about 50%, and the overall disease control rate, which is shrinkage and a stabilization, was about 60% for asymptomatic metastases. And you can see the overall survival actually looks very good there. With symptomatic, the patients are much less, it's much less effective, but there's still a cohort who may be responding. So, in summary, SRS is still a good treatment to have because it's got very good local control. Ipi/Nivo is an active agent, especially in asymptomatic metastases, so there's a discussion to be had about how to combine those and how to sequence. And then finally, some update on the metastatic disease, on adjuvant therapy. So we heard a couple of years ago how dabrafenib and trametinib increased overall relapse-free survival. And this year we heard the 4-year update of what that looks like. So these are patients who had stage 3 disease, so they had their lymph nodes cut out, given a year of dabrafenib and trametinib, and we'd seen the 2- and 3-year survival, but it looks at 4 years, that improvement is still there. So, and actually they did some calculations on this, and it looks as though there's going to be a difference of about 17 or 18% overall. Different stage 3s, so for stage 3 overall it's worth it, but there are some people in whom it's going to be more worth it to have than others. And then finally, that was the relapse-free survival, and this is the distant metastases. So what's your chance of getting metastases beyond a recurrence beyond the lymph nodes? And that's a better guide to whether overall survival will be better. And then we got the overall survival data. This is 4-year data for the Ipi/Nivo study. So this was a study which looked at either Ipilimumab on its own, nivolumab on its own, or the combination. This was the study which, the first slide you saw today, of immunotherapy. And we know that the 2-year data, and now this is the 4-year data. And basically that shows that certainly Ipi and Nivo are much better. And for the first time, we're seeing survivals of over 50% at we're hoping 5 years. So there is a difference. It is small, but if you're that difference, then it may be worth it. And so there's a big discussion, and that was one of the discussions. Could you predict who responds and who doesn't, who would benefit from 2 or 1? But the latest data suggests it's very hard to predict on any of the current biomarkers we have which people will benefit from having 1 or 2 treatments. And so what it also showed, which I thought was very interesting, is that the patients who are alive at 4 years, so each of those bar charts, the sizes reflects how many people are still alive at 4 years and how many are on treatment or on no treatment. And what I was very impressed with is that those people who had Ipi/Nivo 4 years on, actually 71% of them are not on any treatment at all anymore. So they're just off treatment and still well. And that proportion is much, much higher than in the single agent. So with that, I hope, it's my last slide, so with that I hope I've told you about some of the background, some of the what I thought were important breakthroughs or important updates. What I haven't gone through was some quite interesting things about new combinations, trying to combine Ipi/Nivo with targeted treatments, That's a real challenge, trying to work that out. Those trials are still coming, and I'm hoping, maybe not next year, but the year after, there'll be some real updates on that. The early indications seem that combining them might not be as good as putting them in sequence. Some very interesting work on biomarkers. There's a lot going on. Most of the studies are still small rather than large studies, and hopefully you'll hear from Julia later on that actually we need Julia Newton-Bishop. Hi, Julia. Sorry, you've just woken up? Yeah, okay. That actually we're going to need to do this over a much larger scale than the few very, very detailed studies with a few patients. And then finally, there's some very interesting things emerging about the microbiome and how that affects immunotherapy, with some very interesting early indicators that you might be able to modify that in the right way. So that's for next time or the time after. Thank you.